Hello, I'm Dr. Joan Farrell, and I'm very happy to be here at World Schema Therapy Day talking to you about group schema therapy. And with my partner, Ida Shaw, I represent the Schema Therapy Institute Cleveland, which is in Ohio in the United States. First, I'm going to talk a little bit about the development of group schema therapy. In the late 1980s, Ida and I were at the Indiana University School of Medicine in a large psychiatric hospital that was connected with the medical school. And at the time, we'd done a lot of different kinds of groups: combat veterans, women with anxiety, professional women, therapists, and mixed groups of psychiatric patients. And we had observed that in a mixed group, the person who all of a sudden ran out of the group, you had no idea what was going on. You had to run after them because they were typically a borderline patient, and you were concerned about whether they would be okay and safe or not. And what they told us is that they felt weird. They felt different from everybody else. And indeed, in terms of the symptoms they had, they were different. So we had this idea that we should try some homogeneous groups. And at the time, we were trying to develop a treatment for BPD. This was in about 1986, before the first DBT model had been published. And so at that point, people thought that BPD might even be untreatable. We just thought that we hadn't found a treatment yet that fit the needs of that group of patients. So we had been working on that with individual patients also. What we started with was what everyone did, and that was developing skills to reduce their distress level. And we could be pretty successful in helping them reduce their distress level while they were with us. But they didn't use distress reduction strategies when they were outside of therapy sessions. And what we came to know is their experience was that they went from 0 to 100 in a few seconds. And so if they were at a 10 level of distress on a 0 to 10 scale, the kind of things that we use in psychotherapy to reduce distress really aren't going to work at a 10. That's when people felt like jumping off a cliff or out a window. So we were then influenced by an article that Richard Lane and Gary Schwartz wrote on levels of emotional awareness. And what they proposed was that there were levels of emotional awareness that parallel Piagetian levels of cognitive development. And we thought, this makes a lot of sense. Our patients are at this early sensory motor level where it's just all or none, good or bad, 0 or 10. And we needed to teach them to notice earlier levels of distress. So we developed experiential strategies to do that. Then we ran into our third problem. And the reason I'm telling you all this is that it relates to schema therapy. We asked, they still weren't using the skills we taught them, even though they could recognize lower distress levels. And we asked them why. And they told us, well, we're bad and we deserve punishment. We're not going to do things that are good for us. We don't deserve that. And that's when we ran into schemas, particularly the schema of defectiveness, shame, and emotional deprivation. So at that point, we had a package, we thought. And then we also thought, why not try it in a group? At about that time, we also read Jung's first book, Cognitive Therapy for Personality Disorders, or Schema Focused Therapy for Personality Disorders in 1990. And we thought, well, this guy's trying to do the same thing we are. We think that we're filling gaps in emotional learning. He's calling it limited reparenting. We're integrating cognitive, experiential, and behavioral interventions. So is he. And he's ahead of us in terms of the development of schemas. So we were much influenced by that early work. And we decided that we'd try this method in a group format. At the time, our colleagues thought that we were out of our minds and that the groups would be terrible. There'd be blood running down the corridors, it would be total chaos, etc. We were more optimistic. At any rate, after some initial piloting, we did the first randomized controlled trial of group schema therapy, and it was a proof of concept study. 30 sessions of weekly 90-minute group compared to treatment as usual, which at the time was non-specialized individual therapy, not schema therapy. And then a little later, by 2000, we were also developing an inpatient borderline personality disorder schema therapy program that was a 12-week intensive of combined individual and group schema therapy, giving you the background of how this method developed. And of course, in 2003, Young's Practitioner's Guide was published and the concept of modes was introduced. And of course, schemas are more like traits. They're always there, they're dormant, they're a person's view of themselves, the world, other people, their patterns. And modes are states. They're both biological, physiological, cognitive, behavioral states that are triggered when modes are activated, just to give you that little summary. So we completed our randomized controlled trial quite a bit earlier, and we decided that we would present it at the first ISST conference in Coimbra, Portugal. And that was when the planning of a large multi-site international trial of combined group and individual schema therapy began. In 2012, we published the book Group Schema Therapy for Borderline Personality Disorder, which was our earliest protocol for treatment. It was the treatment basically that was used in the first RCT. And then 2 years later, in 2014, we published the Schema Therapy Clinician's Guide, which was much more specific in terms of giving therapists sample scripts, homework, more of a structure. Because we found when Ida was supervising the therapists for the large study, the therapists kept saying, "What do I do next?" And so we thought we better tell them what to do next. And this study was published in 2022 with Arno Arntz, myself, Ida Shaw, and a group of clinicians from Germany, the UK, the Netherlands, Australia, and the US. And it looked at the effectiveness of predominantly group schema therapy and combined individual and group schema therapy. And since then, there has been a lot of work on the transdiagnostic application of group schema therapy to other personality disorders, to social anxiety, depression, complex trauma, and eating disorders. And 20 to 30 session protocols for these different disorders and for therapist self-practice are being implemented around the world. So that's the background. And as I said, this book was the protocol, the first protocol, and is still very useful when it comes to application to borderline personality disorder specifically. And it's available in German, Italian, Japanese, Persian, Polish, Spanish, and French. And then the second protocol, which looks at a plan for individual and group schema therapy sessions, gives you a complete resource to build and deliver individual, group, and integrated schema mode treatment programs. And it's available in Czech, Danish, Dutch, German, Italian, Korean, Persian, Russian, Turkish, Japanese, and most recently, Portuguese. So the theoretical model is the same, whether it's group or individual schema therapy. The theoretical model, the course, the goals, and the treatment components are all consistent with Young's core model. The main schema therapy interventions are the same for group or individual. Limited reparenting, the cognitive component, which we're calling mode awareness, the behavioral pattern breaking component, mode management, and the experiential component, mode healing. Group schema therapy focuses on schema modes. This focus is appropriate for personality disorder, as well as patients with complex trauma, chronicity, treatment-resistant depression, and anxiety. To make the point again, schema therapy is transdiagnostic because we work by mode, not by symptom. But in a group, a focus on modes allows more commonalities to be easily identified. And a limited number of schemas are focused on depending on the composition of your group. So why do schema therapy in a group? Because admittedly, it's more challenging than individual schema therapy. You're dealing with a large family, not one person. Because the research is indicating that it's very effective in reducing symptoms and improving overall quality of life. It solves some of the accessibility and cost problems in treatment for personality disorders, particularly in public mental health settings. The research evidence base for the Clinician's Guide protocol is as follows. The foundation study was the RCT that we did that was published in 2009, our inpatient pilots, as well as the pilots done in Germany by Rees and Vogel. That was published in 2011. There was an outpatient pilot published in 2014 in the Netherlands, and then the multi-site randomized controlled trial with 495 patients published in 2022. The mean effect size was 2.488 with a 95% confidence interval. A huge effect size, given that an effect size of 1 using Cohen's d is considered good. And that is more usual for treatment outcome studies. So as I started to tell you about earlier, in the first randomized controlled trial, the group was an adjunct to individual therapy. We were trying to see if this group that we had devised would add something to treatment for borderline patients. And it was 8 months long, and it consisted of 30 sessions. We had planned for a year, but the National Institute of Mental Health in the US, who funded the study, decided that 8 months fit better into their grant cycle. So they insisted that we shorten the treatment. The sessions were 90 minutes long. They were once a week, and there was a 6-month follow-up. They needed to be in stable treatment as usual to be included. The sample size was 32, which was also the sample size of the first DBT study. And we had 100% retention in the treatment group, which was pretty amazing at the time. These patients had no outside group contact with us, and it was Ida, Shaw, and myself who were the group schema therapists. And as you can see, the top graphs show the blue line is the reduction in symptoms in the schema therapy group. On the left, you see the DIB, which was the diagnostic interview for borderlines. That was kind of the gold standard at the time. And the borderline symptom index, which was a self-report measure. You can also see the large reductions in that measure. We also administered the SCL-90, which is a general symptom checklist of psychiatric symptoms. Again, we got very large reductions. And then we also measured their global assessment of function. And this should go up as you're getting better. The mean effect size here was 2.62. For treatment as usual, it was very low. But you need to keep in mind that at the time, there was little specialized treatment for borderline patients. So in some ways, it was for today not a fair comparison, and we used a different treatment as usual in the large multi-site study. Recovery in the Schema Therapy group was 94%, meaning that they were over 65 in their global GAF score. For treatment as usual, only 25%. And the dropout in Schema Therapy was 0. The dropout in treatment as usual was 25%. Patient satisfaction for the group was also very high. In anonymous questionnaires, their overall satisfaction mean was 92%. And what they rated most helpful in order of priority were the feeling of belonging. I felt understood for the first time. There are people like me, so there's hope. The therapists were patient and consistent. The therapist didn't give up on me. And we learned effective coping skills. You can see, though, that skills was at the bottom of their list. And this is important in terms of the corrective emotional experiences provided by Schema Therapy that are in addition to any skills training. The inpatient open trial that we did, we had 42 patients. These patients were in an intensive program. They got 10 hours a week of group Schema Therapy, and it was broken into a number of components: a psychoeducation component, Schema Therapy, we were calling it component, which was more the experiential work like imagery rescripting, schema skills, cognitive mode work, some more experiential mode work, mode management plans, mode awareness, and modes and interaction was an interpersonal group that included communication and assertiveness skills. And they had one individual Schema Therapy session per week. And the results of the inpatient pilot were, again, very good. The effect size was 2.14. Their mean global assessment of functioning went from 28 to 58. And these were court-committed patients in the US, so they were quite severe. Their recovery rate using the borderline symptom inventory was 85% post, and it was 13% were more than 25 at admission. The outpatient randomized controlled trial, if we want to compare, again, we had a much higher recovery rate, but we also had less severe patients. So the large study that looked at 2 different combinations of group and individual Schema Therapy had a total of 15 sites in Australia, the Netherlands, Germany, the UK, and Greece. The sample size was 495. And the treatment was 2 years of a tapering schedule of 2 combinations of group and individual Schema Therapy versus optimized treatment as usual. It was specialist treatment, pretty much delivered by experts, and it tended to be DBT, CBT, or MBT. The measures of BPD were used: quality of life, therapy relationship, schema mode change, and cost effectiveness. There was some psychodynamic treatment in some of the settings, but a small amount. The treatment protocol for that study followed our group Schema Therapy protocol. The therapists were trained by Ida and me, Skype supervision by Shaw, which included the individual therapists. Individual Schema Therapy followed the individual Schema Therapy protocol in our clinician's guide and in Young's book. The therapists were already either registered as schema therapists in the Netherlands or at least trained. The priority was on agenda in individual Schema Therapy, difficulties with the group interfering behavior. There was weekly peer supervision for the therapists as well, to coordinate the group and individual treatment. this 2 years of tapering schedule, in year one, the primarily group condition had twice a week group, 90 minutes each session, and 12 individual sessions. We came up with this novel idea of a bank account of individual sessions that patients could draw from when they wanted to, or their group therapist could also recommend that they have an individual session. The second combination, called combination B, was once a week group, once a week individual. And in year two, the once a week, the combination B was once a week group, 1 week, and the next week, once a week individual. And in year two, for the first 6 months, group A had once a week group and only 3 individual sessions. In the next 3 months, they had group every other week and 1 individual session. And then in combination B, they had group biweekly and 3 individual sessions. The last 3 months of treatment, they had monthly group sessions in both groups and 1 individual session. So the total number of sessions in the primarily group condition, 120 group sessions and 17 individual sessions over 2 years. In combination B, 70 group sessions and 59 individual sessions. So still quite a bit of treatment. But take into consideration that we started planning this study seriously in 2009. It was conducted over about the next 7 years. And at that time, in all of the countries involved, we were able to provide more treatment for patients than we are able to now in the current public mental health situation around the world. The results, the combination of equal amounts of group and individual did better than the primarily group and the treatment as usual on all outcome measures: symptoms, quality of life, global function, treatment retention. The group schema therapy, the primarily group, had greater variability in the results. There were some therapists that just didn't do that well with their groups, and I'll talk some more about that later. So there were some outliers that brought down the results from the primarily group condition. There, with blind to outcome ratings by the supervisor of all the therapists, there were more competent group therapists in the once a week group, once a week individual condition. We need more evaluation of the various amounts of individual schema therapy plus group that's needed, and evaluation of the competence of therapists to lead a twice a week group. And this was published in the Journal of the American Medical Association Psychiatry in 2022. This shows, again, the differences between the specialized treatment as usual, schema therapy A, which is the green line, that's the primarily group, and schema therapy B, the equal amounts of group and individual. And again, there were large effect sizes, but also large effect sizes for the expert treatment as usual. In terms of the secondary measures, the global functioning, the social and occupational function assessment, patient retention and cost effectiveness, you can see the order of average Cohen-D's. Treatment as usual, 1.15. Schema therapy A, the primarily group, 1.43. Schema therapy B, the equal amounts, 1.69. And here again, we're looking at the effect sizes. The effect sizes between condition A, primarily group, and treatment as usual were not significantly different. The combination of once a week group, once a week individual was statistically greater than either of the other two conditions. To see what kind of effect group might have had when it was added to individual schema therapy, we could look at the Geese and Blue study of individual schema therapy. Here, the treatment duration was 36 months, and individual schema therapy was compared to transference-focused therapy. There were 190 sessions, quite a bit more than the number of sessions, say, in Format B. And the effect size at year 3 was 2.96 for individual therapy, 1.85 for transference focused. So we have a significant difference between these two conditions. It seems that group does add something to individual schema therapy. It's just a question of what combination of individual and group is needed. As I told you when I first described the study, patients had a bank account of individual sessions in the primarily group condition. After the fact, we decided that it probably would have been better to decide when those sessions took place. They probably needed more in the beginning to help them acclimate to the group format. They may have needed reviews every so often. We could probably do better with what we've learned. We've also learned from the qualitative study that was done that looked at patients' reaction to the group that patients were very affected in the group when the therapist was not able to control aggression and ensure safety in the group sessions. They reported that this very much affected their progress and that it continued to affect them throughout the group. Now, of course, that supports the idea we had that we may need more competent group therapists to conduct these studies fairly. It is more challenging to do schema therapy in a group, or maybe any form of psychotherapy in a group, and I'm going to talk about why. At any rate, the twice-a-week group also was too intense for some patients. And some of the patients in that primarily group condition wanted more individual sessions. Most patients did report that the combination was beneficial. And this is from a qualitative study done by Tan et al., published in 2018. There's testing underway internationally for a lot of different conditions. Inpatient in the US and Germany, 30 sessions for avoidant PD and social phobia compared to CBT in the Netherlands, mixed diagnoses and day treatment in the Netherlands and in Switzerland, forensic settings in the UK, chronic depression in Greece, couples group schema therapy in Russia, complex trauma, a 4-week inpatient study was done in Melbourne, and eating disorders in the UK. And since I constructed this slide, many of these have been published. If you do a literature review through one of the AI apps, you can find them pretty easily. So why is group schema therapy so effective and has larger treatment effect sizes than individual schema therapy alone? The therapeutic factors of groups that Yalom talks about in his many volumes seems to powerfully impact schemas. The experience a group provides seems to catalyze or augment schema therapy's main components that are seen as schema therapy's active ingredients. On the left, we have the therapeutic factors of groups: cohesiveness or belonging, the corrective recapitulation of the primary family, altruism, installation of hope, universality, imparting of information, developing socializing techniques, interpersonal learning, vicarious learning, existential factors, and catharsis. Now, some of these you might recall are things that patients said were the primary things that were helpful to them from group: the installation of hope, universality, cohesiveness. And these definitely impact some of these major schemas, particularly seen in BPD: abandonment, mistrust, abuse, punitiveness, unrelenting standards, defectiveness, shame, emotional deprivation, social isolation, alienation, the undeveloped self, emotional inhibition. And the patient report validates this. I'm reminding you again of what patients said. The feeling of belonging fights social isolation, alienation, and abandonment. Feeling understood for the first time fights, again, defectiveness, emotional deprivation. Universality: there are people like me, so there's hope. Fights defectiveness, shame, negativity, pessimism. And before group schema therapy, our patients in the inpatient studies in particular, as well as the outpatient studies in the US, reported that they hated group. And we think it was because they felt like they didn't belong. So it increased their feelings of defectiveness. It was difficult for them to trust. There wasn't as much attention paid to safety and consistency in the general groups that weren't schema therapy. But group schema therapy benefits from the power of the group, the therapeutic factors, because it goes beyond doing individual therapy while a group primarily watches. It's important to activate the group therapeutic factors. Group work needs to be as important as individual work. And the way we accomplish this is that we limit the amount of time that we focus on an individual, and we make that work salient for the group as a whole. The focus moves between an individual's experience and the modes that are common to the group. We weave the common experiences of others into individual work, and we always pull the group in for involvement. And one therapist is always attending to the needs of the group and maintaining connection. And all these things are discussed in the clinician's guide in detail. So the group avoids merely being what patients in cartoons call group discount therapy. In contrast to group schema therapy, CBT and DBT make little use of the therapeutic factors of groups. And we think that's why they have decreased power in terms of their effect sizes. Psychodynamic approaches are limited to using some aspects of the group process, but in a non-directive way, which we think doesn't make full use of the therapeutic factors. I made the statement that group schema therapy catalyzes schema therapy components. Looking at these in terms of the main components, for limited reparenting, group is a closer analog of the family, which seems to intensify the experiential work that we do. Experiences with peers, patients tell us, feel more real than experiences with therapists, because everyone knows we're not real people. We're just nice and we get paid to put up with them. Extended family adds reparenting effects, or refamily effects, as we often call it. In terms of the mode change work of schema therapy, the experience of belonging in the peer family is powerfully healing for the vulnerable child mode. Vicarious learning is powerful in getting through detached protector. Group gives us a bigger stage for the experiential work, and mode role plays with full chairs, not empty chairs, seems to strengthen the impact of that work, of mode dialogues. In terms of autonomy, the group allows us to do adolescent level mode work. The peer group, as we know, is often more important than the primary caregivers in dealing with in adolescent periods. So again, the group work has a very powerful effect. And the group can act as a bridge to life outside of therapy. Often patients in a group will be friends outside of therapy. And in group schema therapy, we don't discourage or prohibit that. We think that often other group members may be the healthiest people that a borderline patient knows. It's important to look at which structural model of group therapy we use in group schema therapy. Is it the interpersonal or process group? Is it the person-oriented group structure? Is it a psychoeducation, skills, disorder-specific group? Or an interactive model? If we look at a typical group, here we have the group members and a therapist. Well, in the interaction or process groups, and these are psychoanalytic groups, encounter groups, interpersonal groups, high emotions and conflict are the desired outcome. And the therapist steps back and lets the group pretty much manage itself. Unfortunately, in our first big training with 70 therapists in a big ballroom divided into 7 groups of 10, we hadn't given them enough instruction about what kind of group schema therapy was. And so some of the therapists were doing process groups. You can imagine with all of the therapists playing borderline patients, you don't need to encourage high emotion and conflict. You have it automatically. And so we had yelling, people running out of groups. It was chaos. This is not the structure of group schema therapy. The person-oriented group, one person is the protagonist, basically, and the group and the therapist are focusing on that one person. These sorts of groups include Gestalt groups, psychodrama groups, problem-solving therapy, CBT. Psychoeducational or disorder-specific groups tend to have the therapist interacting with each of the patients, but not a lot of interaction within the group. These are the manualized groups for specific disorders, depression, panic disorder, social phobia, and also the skills groups of DBT. So what does group schema therapy look like? Well, for one thing, you have 2 therapists, and you have one therapist who is managing to keep a connection with each of the patients, and a large safety bubble is put around the entire group. The second therapist may start some work with one patient, but then quickly we begin to integrate aspects of the other models with therapist involvement. We do want patients to interact with each other. We do focus on individuals at different times for short periods of time. And we do give education. But all of it is with the therapist and therapy. Just to make a comment about the second therapist. Oh, I'll do that later. Okay, the change strategies of schema therapy are basically these 4. The therapy relationship, limited reparenting, experiential or emotion-focused interventions, cognitive interventions, and behavioral pattern breaking. The interventions used change depending upon the stage of the group and the mode of the patients. Schema therapy is unique in actively integrating all 4 of these change strategies. Limited reparenting, the first and one of the primary interventions, begins with connection and bonding. The therapist is fulfilling core needs that were never adequately met within appropriate boundaries. The corrective emotional experience that is talked about as a component of all effective therapy. We're providing safety, validation, support, etc. And our behavior can solve as an antidote to patients' childhood experiences. We want the patient to internalize the therapist's good parent into their healthy adult mode. They typically have not had models of a parent who takes care of the core childhood needs. The task of limited reparenting is expanded in group schema therapy. We have a large family rather than an only child, so multiple bonds are required. Multiple and sometimes conflicting needs occur in the group. There's greater complexity. For example, more modes simultaneously. Flipping modes compounds this complexity. It's very important when there are conflicting needs to find a way to address the needs of all of the patients. Often the experience that borderline patients had in their family of origin is that they were sacrificed and they got the message that their needs were not important. They were not important. They didn't matter. So one of the major corrective experiences of group schema therapy is the fact that the therapists do pay attention to everyone's needs and finds a way creatively to attend to all of them in part. There's more balancing of structure and flexibility needed in group schema therapy. The role of the therapist is more like a symphony conductor. Interestingly, we did 2 pilot studies in the US of our inpatient groups. Once when we had 2 therapists, and then after a budget cut when we could only have 1 therapist. And we found a much lower effect size in terms of treatment outcome with 1 therapist compared to 2. Now, the effect size with 1 therapist was still something like 1.5, which is a very good effect size and can match most other treatments. However, it was less than what we could get with 2 therapists. I think this addresses a concern that Jeff Young stated when he first heard about group schema therapy in Coimbra in 2008. He said to us that he had always wanted a group schema therapy because of the therapeutic factors of groups and the potential effect on reducing schemas and healing schemas. But he didn't know if enough connection could be managed, if the limited reparenting could be adequately maintained and affected. Well, this 2 therapist model that we developed with the therapist always switching, with one always paying attention to connection, solves the problem. Again, 2 therapists are best in accomplishing limited reparenting for a group. However, sometimes it's not possible to have 2 therapists. Often in private practice or in public mental health settings, there's only 1 therapist, and group schema therapy can still be effective. Sometimes in public mental health or in inpatient or day therapy settings, maybe a psychiatric nurse or an occupational therapist, an art therapist, a drama therapist can be the second therapist. And in that situation, you might make that second therapist role more the one of maintaining connection. And maybe the trained group schema therapist is the person who has more responsibility for leading the group. Groups can provide additional corrective emotional experiences, re-family effects, the essential healing experience of belonging. Implicit memories of childhood experiences are evoked by the experience of being part of the group family. A variety of schemas are activated and modes are triggered. Many times we had the experience of putting our own individual patients into a group, and the kind of behavior we saw in the group was quite different from the behavior we saw individually with us. There did seem to be more schemas that were activated, more modes that were triggered. There's a wider range of experiences of belonging, fun, laughter, being silly for the happy child mode in a group. And peers can provide a different kind of comfort and support for scary critic mode work compared to what therapists provide. And we can facilitate some intense emotional experiences, having an identity bracelet that represents the strengths other group members see in you, having a group safety blanket, sending notes to each other's vulnerable child. There are just a lot of different creative experiences that can be facilitated in a group environment. Of course, that can also be a challenge to the group therapists, and it's why specific training in group schema therapy is so important. In terms of experiential mode change work, mode role plays can be done very effectively with a lot of impact in group imagery work. There are multiple connections that are made. You can do imagery rescripting with the whole group. There are a lot of vicarious learning opportunities. Sometimes patients who are quite avoidant and reluctant to get involved learn from watching the experiences of their peers, and that can often pull them into a group exercise. Group experiments have a large impact, and using tangible objects with a group connection as transitional objects can be very effective for the vulnerable child. And again, I think this is a duplicate. Okay. Also, in group, we prioritize experiential work. We seize experiential moments. You can go back to cognitive or behavioral work more easily. It can be difficult or impossible to recreate or return to an emotional moment in a group or a glimpse of emotion getting through the detached protector, a glimpse of the vulnerable child. So we always have a plan for our groups, but the plan can be put aside if there's something that develops in the group that you can make better use of. Cognitive mode change interventions can be facilitated in groups. Trauma processing work, cognitive reattribution, identifying the distortions that maintain schemas. In groups, there's more input and ideas for pro and con lists, ways to reframe negative interpretations of individual or shared experiences, to recognize cognitive distortions. Group members can often remember positive evidence against schemas when the person who actually experienced them doesn't remember. Facts versus beliefs or parent voices can be identified by peers. And often patients can see the effects of schemas and modes in others. I remember a patient in a borderline group who observed a bully attack mode and said to me later, "Oh, I never want to act like that again. I didn't realize how bad it was." Behavioral pattern breaking interventions in group. The group's a microcosm of the world. In vivo practice is possible. Vicarious learning, modeling and extinction opportunities abound. Therapists can underline new learning and accomplishments and lead the validating cheers or comforting words of the group. There are more sources of reinforcement for positive change and pointing out growth. Therapy assignments can support the application of behavioral pattern breaking. The clinician's guide provides a foundation model of schema therapy, group and individual, and ways to integrate the two. It starts out with a focus on welcoming people to the group, establishing safety and connection. That's where limited reparenting begins. There's education about schema therapy. There are education sessions. It's also important to educate patients about the group process and how it's different than individual therapy. In the group, people don't just tell their whole stories one at a time. We learn their stories in parts because we don't focus in an individual way on a patient's history in the group. It develops over time, which is often more reassuring and comfortable for patients. There are mode awareness sessions with the primarily cognitive focus, mode management sessions, the behavioral pattern breaking focus, and mode healing, the experiential focus. We were fortunate to have these very compelling mode figures developed for the clinician's guide by a colleague, Britta Finkelmeyer, a German psychologist. You can see the green character is the healthy adult. The yellow one is the detached protector. The purple one with the belt is the punitive critic. The poor little blue character with the Band-Aid is the vulnerable child. The red character in flames is the angry child. And the little pink one with the teddy bear is the happy child. These are used throughout the book, and we found them very helpful for patients in identifying the different modes and remembering the modes. So again, we developed a foundation program of schema therapy with these coordinated group and individual sessions, which is transdiagnostic. It can be applied to any group of patients. It basically has 12 individual schema therapy sessions described in full with homework and sample therapist scripts for introducing them. And it gives you a cognitive, a behavioral, and an experiential intervention for each session. So there are 36 intervention options. There are 6 60-minute schema therapy education group sessions, 12 60-minute mode awareness sessions, 12 90-minute experiential mode work sessions, 12 90-minute mode management sessions that are a cognitive and behavioral component. So there's a total of 42 hours of group schema therapy. I like to say our best sessions are 42 best hours and 12 individual sessions with 36 options. It gives the structure of the sessions, therapist instructions, therapist scripts, detailed exercise descriptions and handouts for patients, patient handouts, homework forms, and guidance on how to develop a variety of lengths of treatment from the book's material. And this, again, is looking at the foundation blocks of a group and individual schema therapy treatment program. We have screening and preparation for treatment. Depending on what you're doing, you might have, if you're doing a research study, you might have a homogeneous group with exclusion criteria. It might be a closed group. You can also have an open group. Our inpatient program was an open group with people being admitted and discharged at all different times. We pretty much had to take the people referred to us by the community mental health centers in Indiana. So we had very heterogeneous groups. It's here in the beginning that you have the schema therapy education group. Patients need to learn the schema therapy model, the language, and goals in terms of schema therapy, how to understand their problems in terms of schema therapy. There are individual sessions for the screening, assessment, and an orientation to schema therapy. We also use summary forms that translate the patient's problems or symptoms into the schema therapy model. In addition to the content of initial sessions, we set the stage for group schema therapy with what we like to call anticipatory socialization. And that's 1 or 2 individual sessions. We want them to make an initial connection with you, the people who are going to be the group therapists. And we tell them very specifically why we recommend the group for them. We don't want patients to feel, as sometimes has happened in the past in group sessions, that they're just being stuck in a group in an inpatient setting or day therapy, because that's the program and it may have little to do with their needs. We tell them what to expect in the group. Again, that they'll be telling their story in pieces, that everyone will be involved in the group work. And we introduce them to the group ground rules. We discuss their schema mode inventory results as well. We do talk to them about how personal information is shared, that again, we'll learn their story in pieces over time. And this is often quite comfortable for patients. Otherwise, they may tell everything in the first session and later feel like it was too much and embarrassed, and they don't come back. Or they re-experience more pain and fear than they can regulate, and they blame the group. The group makes me feel worse. And both these things can lead to missed sessions or dropout. Often patients will also say, I want to go deeper. I want to share the details. And we need to educate them that the focus on modes and schemas is actually much deeper than a content focus. All this is part of socialization to the role of a group member. We do a lot of early experiential work focusing on connection, physical connection, reminders of the connection among the group. We use strips of fleece, we use yarn, we do all sorts of things where people can see the connections in the group physically. In early sessions, there's a large focus on safety. You have to have safety to take on the coping modes and set the stage for mode change work. We want to develop a safe, accepting group culture where needs are met, a healthy family. And we use that phrase with our group. Good parents need to impart competence and confidence. Ida and I tell our groups, we'll keep you safe. We'll do what's needed within the limits of our power, and we'll get help when needed. There have only been a couple times in 30 years where we had to go out and get nursing staff to come in and carry someone out of the group who refused to get their bully attack mode under control, and they were attacking vulnerable child modes in the other group members. That can't be allowed. Just briefly, the sessions with the maladaptive coping modes are divided into mode awareness, mode management, mode healing, and the first 6 individual sessions. In mode awareness, we want them to recognize their experience of a coping mode and their coping style, and we want them to understand its connection to their childhood experience. It's how they survived in childhood when core needs weren't being met, but today it prevents them from getting their adult needs met in a healthy way. The mode management component, we help them develop healthy strategies to reduce the strength and frequency of the coping modes. And this is where we make an emergency mode management plan. If there is self-injury or impulsive behavior, suicidal behavior. The mode healing part for the coping modes, again, we do experiential work to demonstrate how the coping modes function, whether they're effective or not. And then we work on group cohesion, the safe place image, to take the place of the usual coping mode. With borderline patients, they often start therapy in the detached protector. We can't just tell them to give up detached protector and go out in the world totally raw and open to huge amounts of distress. We need to give them other more effective ways, or ways that have fewer negative consequences interpersonally, to stay safe and to regulate distress, like safe place images and the safety bubble image. And in the first 6 individual sessions, that's where the schema mode inventory results are discussed, the origins and triggers of their maladaptive coping modes, those behaviors, a personal pro and con list to decide if they want to reduce the strength or frequency of the maladaptive coping modes, some mode dialogues, and agreeing to let the healthy adult mode take charge. That's the content of the first 6 individual sessions. Mode change work, again, because there is more mode triggering in the group, a lot of corrective emotional experiences can take place. Because someone flipped to bully attack, they're not going to be rejected by the group. We find ways to make peace, to solve misunderstandings. Belonging in the peer family is very healing for the vulnerable child. Again, there's a bigger stage and more people for experiential work, and mode role plays with full chairs strengthen the impact. The critic punisher mode sessions, again, we want them to be aware when the critic is operating and see it as not them. It's not a part of them. It's an introject. It's the negative messages about self, other people that have been taken in from childhood experiences of needs not being met. A child has a very egocentric view of the world. Anything that happens outside of them is about them. If they're treated in a harsh way, they see it as meaning they're bad, for example. And so that message may be one that their critic repeats to them, even as an adult. The mode management sessions focus on stopping the critic punisher and developing good parent messages. Some of the experiential mode work, we construct effigies of the critic. We develop a good parent message script. We use transitional objects to represent the good parent and to fight the critic. And again, in the first 6 individual sessions for the critic, we're focusing on some historical role plays dealing with the people who have come to represent the critic, work with an effigy, a personal effigy that you've placed your critic messages on because you want to get rid of them. Looking at cognitive distortions that maintain the critic, and imagery rescripting to replace the critic, fight the critic with the good parent of the therapist. The vulnerable child mode sessions, again, we want people to be able to recognize when their vulnerable child is present, the feelings that are involved. We teach them to recognize clues that a child mode is present when their reaction to a situation in the present as an adult is too big. It's brought in situations from the past that have geometrically increased the reaction. And we want to work on fostering compassion for this part of themselves. Mode management, we help them develop an immediate plan of healthy strategies to respond to the vulnerable child needs when they're sad or anxious, when any distressing feelings are present. And the experiential mode work, therapist rescripting, using the good parent script, imagery rescripting, either as an individual or the group as a whole, for times when they needed a good parent and no one was there, and the therapist will go in for everyone and meet the need, provide a rescript. And in the first 6 individual sessions for the vulnerable child, the therapist is going to facilitate soothing activities, limited reparenting, identify the likes and fears of the vulnerable child, go over the rights of children, imagery rescripting, developing flashcards for the vulnerable child that fight schema messages, etc. Some of the important healing experiences in the group for the vulnerable child mode include the experience that when needs conflict, no one's sacrificed. That if you risk being vulnerable, you can get understanding and support, comfort, not punishment. And the experience that others can find you lovable. As I said before, because the group is a closer analog to the family of origin, these corrective emotional experiences are very salient and change provoking. And helping the vulnerable child heal is the heart of schema therapy. This is a large table that you can go back to in the slides if you like, that looks at the different components of treatment in the group and what that session would look like if it was for the coping modes or the critic or the vulnerable child, and also then what the individual sessions would look like. This is presented also for the angry and impulsive child, the happy child, and the healthy adult. So again, this is summarizing more of what's included in the individual schema therapy sessions. And this is often constructed or at least worked on some in the individual sessions. And it's a brief case conceptualization. We call it the problem analysis form. We think in group it's important to concretely translate the presenting problems one by one into schema therapy terms, into modes, into goals, into plans. And the group shares this. So a patient is in one of our groups doesn't have to say, I don't know what this group is doing for me. What does this group have to do with my problem? Because they will have a concrete plan about what the group is doing to help the problem they've come in with. In this example, we just have a problem that one of our patients presented: difficulty making friends. I have no one. I'm lonely. I feel like a loser. We identified the need involved in the problem: to not feel alone, companionship, feeling likable, attention, validation. All of those needs are wrapped up in this problem. How is the vulnerable child mode involved? When I have this problem, I feel very frightened when meeting someone. Is a coping mode triggered? Yes, I get frozen, then angry. I push people away. That's what I did in school. Is another child mode involved? If so, how? Sometimes I get really angry because I feel caught between loneliness and fear. This can lead to impulsive actions, even self-harm. Is a critic mode involved? And if so, how? My punitive critic says I'm stupid and worthless. No one will like me. I hear that constantly. Then we ask the patient to describe the action they usually take and the result. I'm sarcastic and cynical, and the result is that people avoid me. So obviously, the need is not met with their usual action and the pattern of mode triggering they experience. So we've translated this problem into a series of modes. Then we can set a goal by each mode. So for the vulnerable child, the goal for this patient was to be able to calm little Julie and reassure her that I can protect her. For the angry, impulsive child, the same as above. If I'm not so nervous, I'll be less impulsive. For the critic, to be able to stop my critic voice and access the good parent of my healthy adult mode. And the coping mode, to notice detachment beginning and be able to stay present. And then the healthy adult mode, allow my good parent to soothe little Julia and access my safe place image. So these would be the goals that the patient would have in this individual and group program. And then they have a plan. This is important because often the issue of responsibility can be one with patients with personality disorder, particularly borderline and avoidant patients. So the plan includes what step can you take toward changing your role in the problem. In this situation, it was I could try to let my guard down in group and tell people about how scared I get, that I feel everyone hates me and no one understands me. How can the group help? They could give me positive feedback when I reach out. They could validate the feelings I express. And now the group would know that this was their role in helping this patient. We also specified how the therapist could help because we found that often patients had a rather exaggerated view of what the therapist should do. So in this case, the therapist could help by noticing when I'm detaching or using angry protector and gently point it out to me in the group session or an individual. So an important caveat about using any schema therapy protocols. We always attend to the modes present. I had a long conversation with Jeff Young when we were first working on the protocol for the multi-site study because he was concerned about us manualizing schema therapy. But I was able to reassure him that it was a very flexible protocol that had a large quantity of content and interventions, but the way they were delivered depended on the modes present in the group, because schema therapy won't work with a cookbook approach. In a cookbook approach, you're not going to get the important limited reparenting and attention to the needs of the patient that are the foundation of schema therapy. So you can't use a cookbook with structure, and you need to be flexible. We always go in with a goal, or at least I do. Sometimes Ida doesn't need to have a particular goal. She's more comfortable going with what's going on in the group. But I always have a goal, but I'm ready to change my plan based on the modes my patients are in. It's important to be ready to put the content task or cognitive work aside to seize the experiential moment. You usually end up with a more effective result. For example, you've planned to do something on identifying coping modes and their effects on other group members. And you go into the group and half of them are in the vulnerable child mode. Well, I'm going to switch to doing something with, say, imagery rescripting for the vulnerable child. I'm not going to try to pull them into a coping mode. The reverse is also true. If I have a plan about the vulnerable child, but people are very heavily in detached protector, I'm going to have to address that before I can go to working with the vulnerable child. I observed an interesting example of this once in training where the therapists were going to work on constructing an effigy of the punitive critic, and they laid it out and it had this ugly face. Half the group started being nervous and kind of rocking and shaking, and some of them even burst into tears and were afraid of the effigy. And the other half were in a kind of healthy adult / little bit of angry child, and they wanted to fight the critic. Well, the therapist went with fighting the critic. So the therapists playing borderline patients in vulnerable child just were getting more and more and more upset. They couldn't be ignored. So it made the point that you have to modify the work or maybe divide the group in two sometimes so that one therapist can pay attention to what the people in vulnerable child need, and the other therapist can go on with the people who were ready to challenge their critic. The plans from the clinician's guide can give therapists security, and they're a backup. And they're ultimately what you will want to get through, adapted to your particular patient groups presenting problems. But how you do it, the speed, the structure, needs to depend on your group and the modes they're in a particular session. That's part of what makes group more complicated. We do that in individual schema therapy, but we can follow one patient much more closely. With a group, we have to adapt and stretch more. The treatment program in the clinician's guide can be delivered as short or longer outpatient groups, short-term intensive inpatient groups, day therapy programs. Keep in mind that our first RCT tested a 30-session group. 20 to 30 sessions are the groups being implemented in many places in the world in many different settings. When we planned the 2 years of tapering treatment, we had the luxury of doing that much treatment. We don't often have that luxury today, but I strongly believe, and I think the evidence supports it, that you can do as much with a shorter course of schema therapy, whether group or individual, as you can with any other approach to this kind of treatment. It's not that schema therapy is only a long-term treatment. It's ideally a long-term treatment because we're dealing with very deep-rooted and impaired functioning sorts of problems. This is just an example of a 20 and a 30 session protocol from the sessions described in the clinician's guide. You'd still have a welcome and a cohesion building and bonding session. In the 20 session, you'd have 3. The parentheses is what you could expand it to in a 30 session group. Mode awareness and management can be combined. For the coping mode, you'd have 3 or 4. For the critic mode, you'd have 3 or 4. For the child modes, 3 or 4. For healing the child modes, you'd have either 4 or 6. Accessing the healthy adult, 2 or 3. Graduation, 1. And then an extra 3 in the 30 session protocol that you could use according to your group's needs. And this is spelled out in more detail in the clinician's guide. There are some challenges to doing group. One day in training, I decided to spell out all the things a group therapist has to juggle. And here they are. You have to maintain the frame of the group, safety, set the stage for the work. You need to pay attention to the group therapeutic factors and the stages of the group. You want to facilitate the positive stages of group, limit conflict depending on the stage of the group. You need to attend to the modes present in the group members, the goals of schema therapy, limited reparenting opportunities. You have the whole range of interventions of schema therapy, cognitive, behavioral, experiential, your plan and the mode of focus that you plan to work on in that session. And then you have any interfering mode triggering in you or your co-therapist. It's a lot. You need to maintain connection, establish and maintain safety, manage aggression, balance plan versus mode and need present, deal with conflicting needs, respond to overcompensating coping modes, use empathic confrontation is more sensitive because it has a social aspect. You're doing it in front of other people who think that that's going to be what happens to them if they fall into an overcompensating mode. Therapists need to be confident and easy and able to be there genuinely. You need sometimes to have a very loud voice and sometimes a soft voice. The power of the group can be triggering to the therapist, and you have to manage fairly dividing time among the patients because they will notice. Again, there's more complexity and more balancing of structure and flexibility. You have to learn the co-therapist dance. A way to do this is to plan in the beginning who presents what. Sometimes in supervision, therapists would say, well, we didn't know who was supposed to do what. And I said, well, you got to plan that ahead of time. Develop signals that mean, let me say something. Signals that mean, my vulnerable child is triggered. I need you to take over. And you need to not jump into each other's work unless you think that your partner has a mode triggered or the work is going downhill and going very badly. it happens sometimes. Otherwise, you don't want to double team an individual, ignoring the rest of the group. And you need to allow some time for your partner's interventions to sink in. Ida and I had that problem because each of us would think that we had the best way to intervene with a particular situation. And so I would do my intervention, and before it could even sink in, Ida's jumped in with hers. So, and I could do that too. So we had to work on that as a co. We had to work on that particular dance. Again, you need the right amount of direction or limit setting. You need more direction or limit setting for BPD, for antisocial PD, less for others, for healthier patients. You want to maintain involvement and availability while empowering the healthy adult. And again, homework, you want to combine structure and flexibility. Homework provides a shared focus, but we collected it rather than discussing the whole thing. Again, we'd want to allow enough time for experiential moments to be seized. And again, you have to establish and maintain ground rules, predictability, reliability, consistency, engagement, confidence, and a supportive structure. Stability and predictability are basic needs unmet in childhood, which can be reparented in group schema therapy. You need to manage conflict. Conflict will occur in the group, particularly in what gets referred to as a storming phase. And it's an important learning opportunity. If properly managed, these experiences can increase group cohesion. We set firm limits on bully attack, and if needed, give the person a timeout. In the ground rules, patients are told we don't expect them not to have overcompensating modes, but we expect them to listen to our direction as we help them ground and get back to healthy adult. Again, borderline patients tend to really fear conflict. And this was supported by the qualitative study results from the multi-site borderline study that I reported to you. We tend to look at conflict as misunderstandings and jump in very actively to correct them. I remember one patient saying, "We got through it, we resolved it, no one was hurt, no one was kicked out, we survived." And she added, "There was no blood on the floor." We learned many of these things from our first borderline schema therapy group in 1989 that we fondly referred to as the group from hell. We didn't know what we were doing. We didn't have as much structure. The patients knew it. It was chaotic at times. We gave too many choices. We asked them if they would like to do something like an experiential exercise. They would all say no. Now we ask patients, we tell them, now we're going to do this experiential exercise. At any rate, even the group from hell did get better. There's also the issue of what happens when our own schemas get triggered. And again, a group can have a pretty powerful triggering effect. I've certainly been there. Here's where a co-therapist can be a big asset. We wrote another book, Experiencing Schema Therapy from the Inside Out, that's a self-practice, self-reflection workbook for therapists. In the certification that the ISST has for group schema therapy, a day of self-practice, self-reflection in a group format is required. We think it's really important for therapists to experience what their clients do, to experience what it's like to be in a schema therapy group. And again, these groups are for personal growth and growth as a schema therapist. There's also a DVD set of Ida and I doing group with a group of schema therapist friends playing borderline patients. We never script our DVDs. For example, we did a 90-minute session that wasn't scripted. We had just given borderline roles to all of the therapists who were playing patients. Some of them followed them, some of them, I'm not sure what kind of patient they were playing. But at any rate, Ida and I just had to deal with whatever came up as we would in a group. This is kind of old now. It's from 2011. So sometimes I cringe when I watch it because I think that we've definitely improved our methods since then. But it does give you an idea of what schema therapy groups look like. We're in the process of getting this transferred to downloads because we've run out of the initial DVDs. There is a certification in group schema therapy with the International Society of Schema Therapy. The standard level requires 24 hours of training, 20 hours of supervision, and a score of 4 or higher on the group schema therapy rating scale for one recording. The advanced level requires an additional 18 hours of training, an additional 20 hours of supervision, and 2 tapes that's where you have a score of 4.5 out of 6 or higher. And for information on training and supervision, we annually we do the training in standard level and advanced level of group schema therapy. It's also done by Rita Yunin in Australia in English. It's done by Paul Kozyanek and Elena Romanova in Russia, in Russian, in Norwegian by Erland Ashhog in Norway, and I believe also in Poland, in Polish. I think I might have covered the basic languages that it's being done in currently. Sometimes it's live, which is really great if you can do it in person, but more often it's being done now on Zoom because we can't be everywhere. At any rate, you can get in touch with me for this information, or you can also look at the events calendar on the ISST website. Thank you very much for your attention through this long presentation. And I hope that you learned something about group schema therapy, and maybe I've inspired you to try it or to come and get some training and see what you think, or to join a self-practice, self-reflection group. Those are being offered all over the world also, and in many different languages. Again, thank you, and hope to see you in Greece for the conference.